Call this work session to order. We're here to discuss various issues related to opioid. Do we have a presentation? Opioid.
Just some, no presentation, but discussion and some tools we can present to everybody.
Okay, I'm going to turn the floor over to Suzanne first, LaFrance, and then I think you guys.
Okay.
Oh, thank you. Good reminder. Let's go around and identify ourselves for the record. We'll start over here.
Yep.
Could you state your name for the record?
I'm Joan Houlihan with the Division of Behavioral Health.
Great.
For the record, Andy Jones, Director of Health, Director of Office of Substance Misuse and Addiction Prevention.
Wonderful. Forrest Dunbar.
Christopher Grossman.
Suzanne LaFrance.
John Middleton. Pete Training.
Pete.
Pete Peterson.
Great. Okay, so let's get started.
Thank you, Mr. Dunbar. So the question has come up on a number of occasions. How many
Once you shut that up, they're going to go to the screen.
detox rehab beds are available here, and how many do we need, and what's the gap? And Andy, if you'll go ahead and lead us into that discussion.
I will start. I've got two amazing experts here from Division of Behavioral Health who really do understand the treatment side of it. So I always like to start by I am not the expert, so I like to wrap myself around as many of the experts as possible. But I think the question that, Suzanne, that you mentioned of how many beds are currently in Anchorage, but how many we need. That's how many we need is a very hard question sometimes, because there's individuals who are still using on the streets, and we sometimes can't capture all those individuals. But through a partnership with things like the 4As and that, it's helping us to better identify where some of our potential active users are in the city and how many. So it's a new data mapping they're doing for us. So.
Just briefly, if I might.
Yes, sir.
Since this slide is up, I just want to point out that my professional employer is Aquila, which is kind of right there, and I just want the record to reflect that I disclosed that for the purpose of this discussion.
Thank you, sir.
Can I say also, so you use the term detox, but my understanding is that detox and treatment are two different
Right,
things.
these are residential treatment
Okay.
beds.
Okay.
This is on our website, yeah.
Thank you.
Yep. So before we go into this, I should have probably started with this. I know last time when we were at this meeting, there was a lot of questions about data. I think it was Eric Croft who asked quite a bit, and Suzanne about data. So per your guys' request, we actually did implement what we call a data dashboard. Now I know when you look at this, you're probably going, oh my gosh, that's a nightmare. But we have broken it down by the amount of emergency department visits. This tableau does take some time. Come on. There you go. So we've broken this down. This represents on a monthly basis. We have a data team at the state level that partners with local agencies, AMTHC, to help feed into this data. So it gives us a snapshot of things like how much ED visits do we have in relation to opioid misuse, and so this gives us a kind of a good snapshot. We get a lot of questions, obviously Anchorage is broken out as a city, Matsu, but we get a lot of questions of why don't you break it out by every little community? And there's some concerns about making sure that in those small communities that if it's so small, we don't want to jeopardize an individual in the community. So usually anything below 6, we don't report in a small community. We have down below midpoint 3-month average, broken down by age category, so it lets us better understand what age category groups we should be focusing on. As a country as a whole, we seem to see anywhere between that 25 to 34 age group that seems to be the heavily affected. Just varies. The other pieces we have in here, overdose deaths. So this is a current snapshot of what we're looking at right now in Anchorage and around the state. A lot of people will look at these numbers and say, wow, these seem small, but if you take our population base and you were to compare it to other states, we're on track. If we had a bigger population, obviously these numbers would be higher. So we run right with Massachusetts and some of those high-level states. We have a smaller population. I am encouraged to say, where's my numbers? I just got the most latest report. So one of the things we do on a monthly basis is we brief the governor on what's going on. And it's my goal to send these to the mayor also, but we have syndromic surveillance, so we also track pretty rapidly on a daily basis of hospital visits in the state, but also the overdose deaths. And it's been pretty encouraging in our state to see that as of about May 6th right now, we're flatlining in overdose deaths in the state. preliminary data, so we just got to be careful with that, and also with the introduction of fentanyl that is now in the city and across the state, those numbers could skyrocket. Last year in May, we went from feeling pretty good about what we were seeing to almost 35 people dying in a matter of just 24 hours. And so, and that was because the street drug was heavily contaminated. When I use the word contaminated, it usually just means it was mixed with a substance like fentanyl or rat poison or meat tenderizer, you name it. So, good snapshot hopefully here. Naloxone statistics. We get a lot of questions about this. Now, is everyone familiar in the assembly about what naloxone is? Okay, just real quick, it's just an opioid overdose reversal drug. This is actually a really key tool for our state to have, because one of the problems is geographically we are so large, which means we can't put services everywhere. We can't. I mean, it's unrealistic. So sometimes people in a small community, this is the tool that saves their lives. Same in the Anchorage area. If we can't get somebody in to a treatment facility or detox, this is the tool that gives them chance 1, 2, 3, as many as they need to either get into the system so we can hopefully get them into a state of recovery. Naloxone for us, it's a free program, just so everybody knows. We go till 2021 through federal funding. We got about $4.2 million. Currently in the city of Anchorage, we have multiple small organizations like the 4A's. They're probably one of our largest distributors in the state of Alaska weekly, to the point where now we've just given them much more of the naloxone, so we as an agency aren't continually turning around every day. Logistically, it was big. Anchorage Fire Department also carries it. We don't supplement Anchorage Fire Department for them to purchase and administer because it's part of the grant. What we do is we give them the kits, and then when they meet somebody on the back end who potentially is overdosed and there's a loved one there, they're handing these kits as a harm reduction effort. So,
if I could interrupt you for a second. Mr. Trainee.
Good question. Do you provide that to the library?
Yes, sir.
People congregate there, they have the library?
We do provide it at the library, sir.
Beans Cafe, Brother Francis, Distribution, do they all have it?
You know, I'd have to go back. I'm pretty sure Beans Cafe, yes, they do have it. I do remember now bringing it down to their medical staff. And our goal is to get it into Community Service Patrol. We're working and partnering with Muni DHHS right now to get it so they're a distributor. The more people, the merrier, I'd say. The task force here in Anchorage also that's run by Kim Whitaker, she's a distributor. Also, 2 of our biggest hospitals in Anchorage, and I'm excited to say Anchorage is leading the effort on that one because no other hospitals really wanted to touch naloxone delivery or administration with our kids upon release from an ER, and that's been a giant win for us because individuals are coming in with an overdose. There may not be the bed capacity or capability, and when they are discharged, in the past they were discharged ultimately with nothing. And so at least we now have a tool that's saving them, and we're working now to try to link the hospitals up with a peer recovery specialist or somebody who can help guide that individual so they're not left back on the street.
How about high school nurses?
Yes, sir. So really excited about the high school nurses, and I got to give John Garrity a big shout out there, sir. We trained all the Anchorage School District high schools, and instead of the state providing the kits, we actually were able to partner with a company called Adapt Pharma. It's the Narcan we use. Adapt Pharma has got a school program, and they actually have donated the first supply to the Anchorage School District, and then we as a state have made a commitment that we will continually resupply the Anchorage School District when needed.
Thank you, Mr. Chairman.
Thank you.
So I think these are great. I just want to highlight that this is really tied to EMS and law enforcement. So when you look at administration rates, this isn't completely tied to our civilians who are out there saving people's lives. One of the things is that can be a very hard thing to track because when somebody's life is saved, there's still that stigma tied to with use. And so as we build this relationship with our community, with an individual who's heavily using, we're starting to hear more and more stories of success. And so I can say with great confidence in the first year, we actually we documented 144 saved lives. I have in a notebook that I owe to my evaluators about another 100 at least. And that's what we're documenting. You know the number's higher there, it's just people. And so it is working. Now, I'm always gonna end with the naloxone piece. This isn't the gold bullet, the silver bullet. We all know that. It's a tourniquet. But it's a good tourniquet because we're trying to build a system. We're trying to meet the needs, and so I'm happy to say this is hopefully keeping some of our Alaskans alive. We have a thing prescription drug monitoring program. This is a tool that's utilized for our providers. It's a tool that we can use to check and see if there's been overprescribing, if a patient may be shopping, what we call doctor shopping. In Alaska, one of the things that was a problem in the past is the PDMP wasn't a required component for some time. Governor Walker put HB 159 in place, and we're seeing providers now mandatory get into the system. And so in the last few years, we've not had a real good tool. I mean, if you don't put information in the tool, you ain't getting anything out of it, right? So this is now becoming a really good tool for us. You know, we're not out here trying to hunt down physicians. Yes, there are some people who make the industry probably look bad, but those individuals are either, we use a scare tactic with the DEA task force, and they know we're monitoring them. A lot of times what it takes is we find out a physician's overprescribing, yet we start with education. Because we got to balance our approach in this state where we need health providers. And these providers were educated by pharmaceutical reps in the past. So it's time for us to educate them. And so when that DEA task force comes in, we watch their behaviors afterwards, and it changes. And the ones who don't change, we prosecute. And that is a big benefit to us. We have not had a DEA diversion task force or really a DEA footprint in this state. We had one officer. And then the rest of it was pushed down to Seattle. And if any of us, you know how that works in Alaska. Seattle don't understand what we do up here, nor do we get the support, unfortunately. So that's been a big win for us.
Can I ask a question?
Yes, sir.
So I'm looking at this graph, but I don't quite understand. You got 6,000. Maybe 6,000 providers registered.
6,000 provider requests. They're actually pulling in, looking for the data. So it's actually showing that the providers are digging into the data for us. In the past, sir, the data was never being pulled upon.
Okay, so what's the orange line?
Yeah.
That's providers registered, right?
Yep.
So that also looks like it's
about
so 6,000.
Yep. So we have 6,000 providers registered, and then the patient profile request on the blue. That is something.
What percent of providers in Alaska that could be registered or not registered?
Yeah, good question, sir. And I'm going to get that for you right now. So currently at this stage, we are at about 88% of providers who are signed in to the PDMP, which is, I actually think that's pretty darn good. What we have done, we've just issued another letter. This one's much sterner, saying you got to get in or we're going to start taking action. So we are monitoring this on a daily basis. So I'm confident here shortly that'll go from that number up to 100% pretty soon. So the one gap fall we have is we have one person who manages the entire PDMP system. It's not an easy tool, so we have built a task force around this individual who's helping, and so it's really taken a unified effort to get things like letters out and tracking these systems. So the nice thing also I want to talk about with PDMP, we have invested in a tool. It's called a report back card, and so it's a snapshot of the provider's prescribing habits. And it ranks them in the state of who's prescribing more opioids. Obviously, if they're like a pain management clinic, they may be number one because that's what they do versus a family practice doctor. And it's not something to say, shame on you. It's just say, hey, are you aware? And so it's something that was asked for. We put it into place. I have to say with the PDMP, though, there's a lot of pretty options you can add on. If anybody's used to building a system, we're being very cautious about what we add on because the more we add on, that's a cost that's shared to the provider, and the more, if you keep continuing increasing the cost for providers to sign up into a system, they're not going to see value in it, and so we don't want to hike those costs too high up. Number of prescriptions entered into the PDMP system. It's April, I have May coming soon. It's nice to see it's kind of declining. Hopefully we'll see a little bit more. Neonatal absence syndrome. Circle. Rate of newborns diagnosed with neonatal absence system, 3-month rolling average. This is something we need to focus on. This is something that Alaska Regional is doing a lot of work on. We've got a team wrapped around this. I am not the subject matter expert in NAS, but we do have a team of experts that are partnering with the National Governors Association, and we are looking at other states and best practices and how we can maybe implement a model that would help us to curb some of this. some of the discussions we've had with NAS and some of our hospitals here in Anchorage is when an individual becomes pregnant and potentially is using, we found that they want an environment to where they can get clean. And so we've been looking at a potential of, instead of bringing them into the NEST unit is a unit for mothers in NAS at the regional, where they spend 6 weeks, astronomically high costs. And if they don't have insurance, that burden is put on to the hospital and ultimately sometimes the community in Alaskans. And so we've been discussing of why don't we have a pre-environment, like a pre-recovery house of some sort, or risk reduction house that would allow a mother to come in. She gets the services she needs and the care she needs upon delivery of her child. And we've seen models in Lower 48 where the individuals then have had less time within the healthcare facility, which has been good. Release that individual then into a recovery house. There's one in, like, for example, Valley Oaks in the Valley. We've got a phenomenal program that works to get the mother and the child back to a state of recovery and integration into the community. So this is our chart. It is not perfect, but I gotta say, I gotta give shout outs to my team. New York Times says it's one of the best charts they've ever seen. So I don't know if that's good or bad, but hey. The other thing we're working on is we're going to start to work with ANTHC. We just signed an agreement, and we're going to start to work to take their data from rural Alaska so we can get some of their data also, that's a missing part in here for us sometimes. On the trooper side, we actually are going to be launching a dashboard also soon here that's going to be starting to show seizure rates, of different substances in our communities. We will show seizure, but we will never show the value of it. The reason for that is, if anybody's in the drug trade movement arena, it's extremely expensive to buy drugs up here. Cartels aren't stupid, and they know that, and so they're monitoring this. And so if we continue to promote, look how much we seized, it costs this much, as a cartel member, I would be like, man, I'm coming in. And they've already started doing this. So what we've actually done is we've worked to where we've taken the grams seized and we're equating into doses, because I think the general public can relate better to, oh my gosh, we just seized, 400 grams of let's just say 1 gram of heroin. That was 10 doses. So we're trying to make our data, we're trying to make our information as public friendly as possible. So I like to say I'm a health official. I always look at everything in the eye of a not a health official. And so if I can't make sense of any of this, I don't know if the public could.
Just on that topic,
yes,
are
sir.
you working with APD or the troopers to create kind of an agreement on that topic where we shouldn't talk about the value rather the dosage? Because I know you see those reports, not your office, but other offices, and it seems like it's a good strategy that we wish to adopt it.
Yeah, so thanks for that question. We just became, I'm glad you mentioned the law enforcement, so we just became what we call a HIDA. It's called a High Intensity Drug Trafficking Area that's funded under the Office of National Drug Control Policy. We are the first state in almost 20 years to get the HIDA designation. Now, what does that bring for us, right? That brings up to and probably over $3 million annually into our state, and it allows us, it's all tied to interdiction, eradication, enforcement efforts. There is a component in there that also allows us to use it for treatment, but we have to work with ONDCP, Office of National Drug Control Policy, to be cleared on that. That HIDA board is made up of Anchorage Police Department, some of our bigger police departments, the Mat-Su area, Fairbanks, those areas, the Alaska State Troopers, but it's also got our federal agencies on there. So that's going to be a great influx. We do partner on the health side of it, but also on just the incident command side. One of the things we're partnering right now with Anchorage Police Department is with Captain Case, and we're looking at trying to implement a risk reduction center, is the best I can call it. So when an individual, first off, Anchorage Police has got a small diversion program in place. Got to give them credit for that, especially when we don't have the services for them to sometimes implement that. And so Captain Case has applied for a grant. I just applied for a grant. Hopefully that if we get approved, we can feed that. And our goal we'd love to see is some type of center to where the police could end up dropping an individual off. So we're not diverting them into the prison system. So I'm going to add kind of right onto that, if that's okay, with the prison system piece. Prison systems in our state, I think we all realize we have a horrific recidivism rate, right? So what are we doing about that? I got to give corrections credit. They are changing their mindset. They are carrying the naloxone now. Ever since, unfortunately, Kelsey Green passed away, we implemented hard and behind the walls to make sure that all of our POs, all of our COs, and that's probation and correctional officers, are carrying Narcan in there. Also, we got a Vivitrol program. Vivitrol is a version of a medication that can be used for opioid management. It's not the silver bullet either, and it's not meant for everybody. But we were donated a hefty supply, and they've been doing 30 days upon release a Vivitrol shot. It's something to start, but you're just now starting the management of an addiction, and you're going to be about to release from the prison system. And so when you're having to, as a formerly incarcerated individual, try to integrate back into your community, being an active addiction is a pretty hard thing to also lump on when you need to pay restitution and all the other things. So we were able to divert about $1 million from carryover funds that'll go over into DOC, and we're going to start a pilot full medication-assisted treatment program. That's Suboxone we'll start with, and then we'll potentially look at other things. But our goal would be to start. You come into the prison system, let's get you started through the treatment process right away, and then hopefully upon release.
Just a quick question.
Yes,
on
sir.
that topic. So you said $1 million.
Yes, sir.
Would that be administered by the department? Because historically, for the last 5 years or something, the division has put out about $1 million for MAT and not really been able to get that program rolling.
Yeah. So here's what we were thinking, sir, is the money would be within health, but then I will have the authority to RSA those funds right directly over into the Department of Corrections, who will then be able to execute the program. And then what we'll do is embed a few individuals from counter drug support to be the program coordinators to help manage the program. So we are looking for the fastest ways sometimes to get this money through to the right agency or department. So I will admit it's been a challenge for our state agencies to get money out, and not a very easy way for our providers or
That's
organizations.
isn't enough for a provider to run a real MAT program because
Yeah.
of the cost of medical professionals. And so if it's within the division or the department, it makes
Yep.
sense. But if it's outside, we've seen $1 million isn't enough to hook anyone to do the job.
And we're going to keep this one, I think, sir, inside. That's my goal. I want to build this is just all Andy's idea, right now, but we're kind of thinking like a rapid response team within, and I want to really isolate it. So I'm going to be meeting with the superintendents across the state next week, and we're going to start to have this discussion of where should we pilot this? Should it be at Anchorage? I mean, we even talked about the concept of maybe we take Anchorage Complex and we actually bring some of the women from over at Highland in, and we have, so there's been a lot of discussion already starting to occur at the DOC level. So I got to say, I'm very encouraged to see that they're accepting of Suboxone. I know it gets a bad name for diversion. I really do, but it is a tool to this fight, and it's a good tool. And so we have a horrific diversion program in the prisons, and I've had the opportunity to travel around the country and look at good and bad prison programs. And what I've come to the conclusion is you got to remove the demand. And how do we remove the demand? We're going to put Suboxone in there, get them set up, and then these gangs that are playing this game, and what they like to do is they bring drugs in, they'll distribute it out. You get hooked, and then when they don't have a supply anymore, what they'll do is they'll say, well, I don't have a supply, but you're going to go into withdrawal, so hey, guess what? Here you go. And so they're continually, they've got a pretty smart model going in there. So we're going to take that Suboxone aspect and say, great, you're already feeding them this anyway. So how that concept will fall out, we'll see. But
Thank you.
yes, sir.
Is this the end of your presentation?
Yeah, you guys want to ask some questions? Or I have a few things for Anchorage specific, if you'd like, some last things that are happening.
Do you have a presentation as well, or is this combined?
No, I was mainly going to take questions having to do with detox services, especially in the Anchorage area,
Okay.
and also gather feedback from you, because we've got this $12 million coming up that we're going to be giving recommendations on how to distribute it. And
Good. I'll note for the record Mr. Croft has joined us. Suzanne, what's your preference?
Well, Andy wants to go ahead and finish the part that pertains to Anchorage, and then I think we should have that conversation with our local DHS people too about the funding that's available
Okay.
and what options.
Okay. Thanks. Sounds good, Mr. France.
Last little bit for Anchorage that I'm excited to announce. So I had the opportunity to travel to Vancouver, British Columbia in November, and I just came back last week. And we're watching a lot of what they do. Now, they have active injection sites there. I'm not saying I'm bringing active injection sites. But what they did do is they've been using what they call fentanyl test strips. So what they'll do is they'll give these strips to the user once they leave with their needles. And these users were going through and testing their own drug. They saw a dramatic decline in overdose deaths because the user then understood what they were taking and then they were actually using the drug appropriately. So when I heard that, I was like, oh man, these strips are $1 a piece. So here's what we're going to do. I just bought $10,000 worth of these strips, dedicated to the Anchorage area, and then we're going to tie it to a circumpolar health study to make sure, is this going to work? Are we going to see a reduction in overdose deaths? Now, if we see a reduction in overdose deaths, the good thing would be, one, people live. Two, it doesn't put such a burden onto our EMS services, which I think, I'm not part of the assembly or the city, but you listen to the news and it seems like that is a tax on our services. So I'm excited to see that happen. That should be launching any day now. I'm just waiting for the supplies to come in. The other piece that we just purchased is torpedo tubes, sharp shafts. So they're very small. They're about this long. I just bought another 10,000 that will go to the needle exchange sites. And so my goal is that they'll be handing these out, especially in the mobile unit. And it's a process of saying, safely dispose of your needles or bring them back in a safe manner. And so we don't have things. I have a picture on my phone here of Westchester Lagoon where I saw a whole bunch of needles, some Narcan there, and that's the last thing I want. So let's give them the tools necessary to make sure that the city's clean and that we can actually enjoy our parks.
So, John, did you have a question?
I didn't quite grasp of these strips
Yeah.
are used for what?
So fentanyl is now into our community. It's being mixed with heroin. And so when an individual comes into the 4As, they'll get needles. And what we'll do is we'll be giving them this little self-test strip with some instructions. And so they'll leave. And before they go to use their drug, they can actually dip this in, and it'll give them the indicator of fentanyl's present. And if fentanyl's present, and then what Vancouver has done, British Columbia, is they gave some very little instructions like use less, don't use the same as heroin. This is 100 times more powerful, or things like that. And so we're hoping that we will see reduction because people are going to be using that drug appropriately. It's kind of hard to wrap your head around a little bit of that harm reduction, but we see some really great results.
I have a specific
Hold on, Chris. So we got John, followed by Eric, and then you.
Not having any experience as a heroin addict.
Yes, sir.
Seeing occasionally needles around. I mean, what is that damage? So they're in a car or something like that, which I've seen, when they're shooting up and they have the needle and they just fling it out of the car like a cigarette butt. Is this, and now you're saying, but we're going to teach them how to be socially responsible.
So
do they care?
You'd be surprised. One tactic that's happened is the needle exchange says it's a needle for a needle. And so that has been a great tool for Anchorage, I have to say. Now, you're not always going to have people who are going to follow that. And so we're trying to say that if you're going to throw those needles somewhere into a trash, please use this torpedo tube, because the last thing I want is workers getting stabbed or stuck or anything like that. So we are trying to have that, that educational aspect. And it's surprising. We did some focus groups actually down and worked with individuals who are actively using still at the needle exchange site, and it was surprising. They said, we do care. We don't want to leave them. So I'm just curious who are the ones leaving them around in our community still. So it's one of those, I know when you hear the word 10 grand, it's a lot of money, but in the grand schemes of the amount of money we do spend, that seems like it's a low cost to study to see, is it going to make an impact change on our community here?
We're spending that just on advertising our current absence. So
it'll be better.
Chris, do you have some specific on
Yeah,
top for
the
the
fentanyl issue. So just to measure, so you understand a benchmark of how it is. I know this specifically from a personal friend whose roommate died last weekend from smoking what normally would have been a normal dose of heroin, not injected, but it was laced with fentanyl, and the smoking of the fentanyl caused his death. Right, where normally you would be fine to smoke if you were engaged in that environment with heroin. Once you add that fentanyl, it's immediately a different game. It caused someone's death who was a regular user of heroin. And so that's the difference really, and why it's important to know what's out in the marketplace. It's very real.
Okay, I just didn't grasp that it was a test.
Yeah, there's only one other state in the country that's doing this. So we're lucky because we don't have drug paraphernalia laws in the state that's allowing me to kind of skirt this and play this game. I'm hoping we have some good results come from, because if this works, it's something we're going to continue to do until the new drug emerges.
Mr. Croft and Mr. Trinity.
Yeah, thank you, Mr. Chairman. Yeah, it is balanced, and I've looked at the information on the cities that provide safe places to shoot out of that. I'm not comfortable with it yet, but this is a nice in-between place where you can help people survive and not quite tackle that. I've meant to for a while. I worked with 4As to get them a little more money with the help of these students, but to get some more information. That is, I've talked to 4As about in the needle exchange, anonymous, having a information thing. Hey, in return for this, can you just answer 4 questions? And again, we're not keeping your name, but did you start from opiates? How long have you been going? I just want, it's so hard to get information on this thing, right? We have these weird windows into it. Opiate deaths, reports to emergency room, seizure of contraband of drugs, and those all are imperfect views into how much is being used and what's going on. I'd love your help on working with 4As, again, in a way where we can be very clear to the users that we're not keeping, we don't care what your name is, but we want some information on how long, why, what.
We could do that, sir. I think the one thing that 4As is starting to share with us, they're collecting where's the person from. And so we're actually been able to plot this on a map. Boy, I'll send it over to you, Eric. It's pretty shocking how many people are not from the state that are coming in. And so the other piece, though, is I think we're at a perfect opportunity because we haven't deployed those fentanyl test strips. And then Ryan Ray from over at Circumpolar Health, he's going to start drafting these questions that 4As. That was kind of the I won't say blood deal that we made was, hey, you know what? We'll do this for free, then let's partner to get some questions. And so I think that'd be great if we have some specifics we want to start looking at.
Exactly right. Let's share that. And we stepped up with some money, so we can both do the same thing. We're providing money, and we want some information just to help us understand what's going on.
I agree. So I think we're in a good opportunity there.
Mr. Train and Mr. Peterson.
How much of the product has to be utilized to make the test strip work? Because the person who has a product, they want to use it.
Definitely.
They don't want to waste any of it on a test strip. Even though you're telling them to save their life. At that point in life, they don't really care about that. So how much of the product is utilized even to really you on the test strip?
So you're saying if somebody was to dip the product in, how much does it take for the test strip? It doesn't take much at all. I mean, if you had little dustings, like little individual sugar grains in there, it would activate it and tell you. Now here's the danger, obviously, with the drugs that are on the street. So a picture of how drug dealers actually mix this stuff in Alaska. The heroin comes in a lot of the times. I've seen some drug dealers actually take it to where they open their Ziploc bag with heroin. The fentanyl comes in via mail from China, zips it up. I've seen some shake it, and they say, oh, we're good, it's mixed. And that's been a problem for us because we're seeing what we call hot spots in the drug. And so my fear is sometimes if one person has one, and they're like, oh, that's good, and then they don't do it again, it could be no fentanyl in there because it wasn't mixed correctly, and then the next one in that same batch could just be pure fentanyl. So that's some of the messaging we need to be really smart about. And to do that messaging right, we're working actually directly with the users to make sure, I mean, we could sit here in a room and say, this is good messaging, but if we don't have a user who's actively in here, we got to make sure what are they going to be receptive to, how is our messaging going to work, what is their reading level, things like that. So I've got a team out in the field right now kind of working on those avenues.
Thank you, Mr. Chairman.
Thank you, Mr. Train. Mr. Peterson.
Thank you, Mr. Chairman. So fentanyl has been around for a while. It was made as I believe, a horse tranquilizer originally, and so it's being made over in China now, and it's coming in there. Is it being manufactured legally in China, or is this sort of a criminal enterprise that they're taking advantage of the American market?
It's a great question. I so wish I had my slides for you guys. I have this great drug trafficking slides I just did with Providence today. But yeah, so fentanyl is produced over in China by syndicate labs, so it's completely illegal. How it's ordered and brought in here, they utilize the dark web. If anyone's ever, it's so easy to get into the dark web and play around. So people order it, and then it comes primarily via mail into our community. It will be body packed sometimes, but more and more people are getting pretty nervous with body packing pure fentanyl into them. Notice, I'd be nervous body packing anything into me. That thing explodes, you're done for. So I have to say this, we are working with the Chinese government right now, and I just as today got tasked with writing a letter to the president of China to talk about how we can partner with them to start looking at maybe interdiction efforts over there, especially since we have some discussion going between Alaska and China on trade deals. We're going to actually hit this piece. The one last piece I want to highlight on that makes us pretty vulnerable in the state is Anchorage International Airport has an exemption. So aircraft can fly into here, they can do offloading without having to go to customs. And so we are a lot of the times a hotbed potentially for drug trafficking and movement, and we don't even know it. Yet that's an economy booster for this area, so we have to figure out how we're going to address that. And I think we have to do it on the front end, and China's been very open to these discussions with us. So I'm hoping we see more with that. It's a lot of work with DH, the federal 3 names, which is so much fun, but Alaska is actually not going to wait anymore. We're going to directly go and make that contact.
Thank you.
Thank you, Mr. Peters. I had a question before we move on about NAS.
Yes, sir.
So here, it's right here. What are the symptoms of NAS as the children get older?
Yeah, I'd need to probably pull the data for you on that. I definitely know the symptoms as how they go through the withdrawal, but if you
is it a permanent like the way fetal alcohol syndrome is? The fetal alcohol effects, does it have that kind of long lasting damage to the child?
Usually it's not, no.
Good.
But it can often be coupled with that.
True.
Those things are discrete.
Have you guys ever Googled NAS, opioid, with NAS? If you ever Google it, it almost made me cry. I got 2 little ones, but there's some YouTubes that actually show a child going through the withdrawal period once the child has been born. You want to talk about a sobering video? My gosh, I recommend you guys to Google and just take a look at that. It's pretty hard to watch, but it is pretty sobering to see. So,
Any other questions? All right, moving on.
Okay, do we want to just talk about detox services in Anchorage? Or what's
Or you can
available
also-
across the state?
What is the best way to structure that whole issue when it comes to detox, treatment? How do we even approach it in terms of what resources are available? I don't know if people are more likely to seek treatment in the community in which they live or go outside to other communities in Alaska or outside Alaska. So, my interest, and I know it's come up from other members too, is just where are we at? We hear over and over that there aren't enough beds, and yet we don't know how many there are or how many we need. There was that piece in the daily thing you and I had talked about, Andy, about the mother from Birdwood
Yep.
whose daughter died of an opioid-related infection, and a big part of that piece was there was nothing available for her daughter for treatment. So, sorry that was long, but whatever way you think is best in which to approach that, because it seems unwieldy with different funding sources and conflicting information that we hear in terms of data or at the site here.
Okay. So, detox or withdrawal management, as it's called, is obviously different from residential treatment. But it's complicated right now because of the opioid thing, because previously it was mostly if somebody needs detox, it's because it's alcohol withdrawal. And that can be very dangerous, and you do need, a residential medical detox like that. And in Anchorage, currently, and for quite a while, we just have 1 detox, 16 beds. And a year ago, when this was run by Cook Inlet Tribal Council, they would have always over 50 people on the wait list per day, and it would take weeks of calling in every single day to keep themselves on the wait list and to be able to get in. But now, then South Central Foundation took it over, and they have managed to make it much more efficient. So last time I checked with them, but that's been at least 6 months ago, they said that almost anybody can get in within 2 weeks, and some people sometimes just within a day or 2, especially the priority populations, which are pregnant injection drug users, all injection drug users, and then women with children. They get priority with them. But, so 16 beds with the number of people here is obviously not enough, but then again, with the opioid thing, most people, unless they have like medical complications along with it and stuff like that, they don't need necessarily the residential medically monitored detox. They can do, some people call it ambulatory detox, but they can go to a physician or a substance use disorder place that distributes like buprenorphine or whatever, and they go through an induction process, which means that they kind of taper them off of what they're taking and they start them on buprenorphine in the daily dosage. And the medication-assisted treatment is necessary for almost every opioid addicted person of the lungs. So, I mean, I get lots of calls every day, and most of the opioid ones, they need the medication-assisted treatment. They don't necessarily need a medical detox, but the alcohol folks do.
Could I add on to that real quick? I think that tells us something we've been looking at. This system is complex, right? The continuum of care. A lot of continuum of cares are complex. So one of the things that DBH, the commissioner, OSMAP has come up with is that we're going to create a treatment page that really describes in very general terms what is the cycle of care. So people, it's going to be Alaska individuals talking about it. So it's going to have like a 30-second video. Now I know that sounds kind of fluffy, but information is king. To say here's where you need to start. And it's just and if there was more information, so if we dedicated just to that. Because we realize sometimes people just don't know where to start, and so as a tool, so that's something our public information team is rapidly working on right now.
Thank you. Mr. Peterson and Mr. Wellington.
Thank you, Mr. Chairman. We have a methadone clinic downtown here, and I've taken tours through that several times, and every time I spoke to Mr. Green, who runs that clinic, there was a waiting list. Is there still a waiting list at the methadone clinic?
They have recently, with federal funding, gotten additional funding to where they have more than doubled their capacity. So no, people can get in there almost right away too.
Because for a long time he was only accepting pregnant women.
Right, yeah, that went on for a couple of years, I think. There's also another methadone clinic in town. It's a for-profit, but they are state approved and they can accept Medicaid. So they also do buprenorphine and Vivitrol as well.
Thank you.
Mr. Wellington.
So there's detox and then there's the recovery afterwards. So with alcohol, you're saying it's so bad, there's no drug that can really help, so you have to have doctors there to take care of them. With opium or heroin, you can use drugs and it's not as horrible. But after you detox them, is it still like a year of recovery? How do those compare?
Yeah, with alcohol, if their withdrawal is so severe that they do need the medically monitored detox, then they're assessed and usually need to go into residential treatment. Part of it just depends on their support system, but usually into residential treatment after that. And that average length of stay is like 60 to 90 days right now in those programs. The opioid withdrawal ones, some of them do, like say, need the medical detox, and we do have some beds specific to that, but most of them could get by with getting hooked up with, like for instance, a buprenorphine provider, where, like I said, they kind of taper them off and then induct them start them on the buprenorphine. But it's recommended that people stay on buprenorphine for at least a year, and most longer than that, even. But they also need to have treatment along with it on an outpatient basis.
And I think if they're in an ER, correct me if I'm wrong here, but if they're in an ER and it was someone who's detoxing off alcohol, they're going to take a priority with that bed probably versus the opioid is what I'm familiar with. So sometimes, and that's what can compound the problem, because if there isn't a bed even in the hospital setting, they're released.
You have a follow-up to that, and then Mr. Constantine.
So when you say how many detox beds, is that private free ones for people, or is there? I have money. There's a doctor who can do it. So are there other alternatives if you have money to pay?
the 16-bed facility I was talking about, that's run by South Central Foundation, well, we used to give them grant money, but now they get so much money through Medicaid that we don't give them grant funds anymore. So they do build Medicaid, and they accept indigent people as well.
It was private practice.
But if you have money, is there, I mean, can other places I can go and just pay, I have a problem and I have money and I'll just pay, and then there's more than 16 beds.
Not in Alaska.
Not in Alaska, so that's it. So you want the detox, you got those 16 beds.
Well, there's, yeah, that's in Anchorage. There's 3 other ones throughout the state. There's one in Fairbanks and Juneau and Soldotna.
Chris.
Thanks. A couple of questions. What's the other provider then for the methadone? The
It's
medication?
called Anchorage Treatment Solutions.
Okay, and then I'm glad to hear you say that MAT is treatment is still required, right? Because a lot of people, when they hear about medication assisted, their brain stops at medication, and they think
Yes.
that's the treatment. And I continue to hammer on the fact that you can eliminate the first behavior, but if you don't get rid of the patterns and the habits and the social networks and all the things that a treatment course does, you won't change that. And I guess I'm really glad to hear that, because for a long time it seemed like everyone was turning to MAT as the solution.
And there is a place that's moved in, like this provider, into Fairbanks and into, I guess they're even in Wasilla, but Kenai. But anyway, it's called Ideal Option. And apparently somebody can go up there and the very first day they can get takeaway medication, no, buprenorphine, and no treatment along with it. And then apparently there's all kinds of diversion of it going on the streets.
And this is definitely not an Alaska-specific problem. This is a national problem. Like
Yeah,
any
yeah.
event I've ever dealt with, there's always somebody who's going to come in and try to feed off. And the nice thing is we have some checks and balances. Hopefully that'll, push some of these individuals out. But I'm glad you mentioned that too. The M, if you only the M, we're in trouble. There is no silver bullet, and it's really those recovery services that are so essential. And that's why I continue to tell people is we got to make sure that we build on the back end of the recovery and make sure there's enough supportive services, but also a balanced approach with the medication services too and treatment. So,
Last follow-up there's a threat that I'm hearing in the community, threat for you guys, I think, and not you really, it's higher up, I think, that all of the roads of the trouble that we seem to be seeing lead back to the lack of key services in the community. The disinvestment over many years where we're seeing services diminish. Homelessness, addiction, mental health, corrections, all of these services are being shrunken. And the net impact is that on our streets, outside of the medical facilities and the housing, the shelter facilities and the jail, we have this incredible phenomenon that's occurring of a robust street trade in trauma and trouble and addiction. And what I see coming is lawsuits to the state, much like when the trust was founded and when the trust was fixed. The second time that a question is going to be asked of the courts is the state fulfilling their duty. And I know you guys aren't at that level. That's kind of a step above your pay grade. But you are the nexus of where the solution lies. And so glad to have you here working on this issue because it's incredibly complex.
could I add on to that if you don't mind a little bit? I agree. That was something me and the governor were just talking about today, and it's a challenge with such limited resources. Hence why we've been tasked with writing so many federal grants. Federal grants are great, but I think all of us realize that the more grants I take in, my staff turns into a granting agency and not an operational agency. And so I'm trying to balance that approach. And it's a lot of requirements, which then get put on you as a community, and it's not fair. So some of the other things we are doing is we're working with some businesses in this community, the hospitals, some very powerful organizations to try to really say healthy workforce, healthy business, and we're starting to see more donations come in, and that's some of the things there needs to be a public-private partnership if we're going to address this issue, because the state alone can't. I hate to say it, I don't have the money. I don't, and even at the federal level, the funds that are coming in, the problem is these turnaround times to meet their needs. 1 year to execute an MAT window, that's ridiculous. And so I think the federal and the state has some work here, right, to do. But if we come together, I think we can expand that a little bit better.
Eric,
So-
I'm sorry, Mr. Croft?
Many of us, most of us, my friends and I, in particular, have been trying to get a handle on the availability of treatment services. And I know there's a variety. And how it's changed over the last 10 years, particularly after SB 91. And it's been frustrating, at least from my perspective, in that I keep getting mixed messages on what has happened. And I think a component of it is a switch to a Medicaid funding model, which has benefits, a stream of money and other things, but all out of a grant or other model into a Medicaid model. And I can see why that happened, but can you, either of you, anyone, give me a 30,000-foot level picture of, have we increased, decreased, stayed the same, or changed the overall picture of treatment? And again, it's big picture, alcohol, drug. Has it declined, increased, or changed?
You and me.
Yeah, I've been working in this field for like over 30 years, and as far as the availability of treatment services, I don't think they've changed much. They reduced. Actually, when I first started working here, I started at Southern Army Clitheroe, and they had a 35-bed detox. You know, some of the things have gone away. The funding has not increased, and so the services have not increased. And
A promise of 91 was kind of, we're going to do criminal justice reform and we're going to fund this. And when I talk to state or legislators, they say we increased funding. When I talk to providers, they say it's decreased. It's really frustrating for me as a public policymaker to try and just know what's going on. So just from your perspective, I'm not trying to get you in trouble,
No.
it's decreased?
Boy, that's a good question. So I would.
What's the?
Yeah, it
what
is
are
the question.
questions,
Yeah, I'd
right?
agree. You know, with advancements and probably with our grants we've added, but ultimately it's still probably decreased. Wouldn't you say?
Probably.
Yeah, I would say it's ultimately still, Eric, decreased, even though we put grants out there. Andy's opinion with SB 91, right?
Right.
Yeah, we had some type of plan. There was no great implementation plan on how we were going to execute this in a phased approach. So we were like, SB 91, and we were supposed to just adopt and take it. And that was, I think, potentially a wrong course of action to take. We should have had a phased approach as we built that model in, because what's happened now?
You mean the Medicaid model or some other model?
The SB expansion of treatment to support SB 91 and the Criminal Reform Acts, obviously. So that's a big, big delivery piece. Now, we've got some good work across the state that I've seen, things like the potential of Norton Sound Health opening a facility, but these are pretty rural Alaska places. So through the years, we've seen a decrease with a little bit of advancement in these last 2 years, but nowhere where we're probably ahead of what used to be, maybe. So.
So that's also the question, right? It's not just how we decreased, it's also, how we decreased from 30 years ago, right? But have we decreased as far as we would have given the overall budget cuts had it not passed? You know what I mean? And have we increased in the last 2 years but decreased in the last 30? If that makes sense.
Yeah, it does. I mean, my fundamental continuing criticism of 91 was, from what I can tell from Texas and Sweden and God, if Texas and Sweden agree on anything, they're going to do it, right? And they both seem to have implemented alternatives and saved the money on the back end, right? Not say you're out of jail, but say here's your options and here's your things, and then reap the benefits of it. I continue to think we just did it completely backwards.
I would have loved to have that phased approach where it would have been like by 2021,
Yeah.
blah, 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 you know what I mean?
We don't have to build a prison because we have done all these.
Yep.
I just would add, instead of a kind of
Just the probably decreased is the answer. I'm sorry.
Yes, sir. Probably. I would say we're.
unequivocally, and here's
yeah.
how. since SB 91, if that's the frame you're going to put around it, there have been over 30% decrease in funding for grant-funded beds, and the Medicaid has been flat. It's increased to a degree at that point.
Yep.
So, but there's been no additional increase with the cuts from the correctional system. And so, while they did implement a new pretrial release program that just started 4 months ago or 5 months ago, the funding has cut by 30% for the treatment providers since the recession began. And then SB 91, the demand went up. And so, it's not maybe, it's unequivocally for sure.
But they didn't cut it because of SB 91. They were in the process of cutting it.
Because of reality. Yeah, because of reality.
I don't want to hear testimony from him, but yes?
Yeah,
Okay.
definitely.
It's not a fuzzy one.
It's a definite.
Thank you, Mr. Chairman. So, if you could make magic happen and rebuild a brand new quick growth center, how many treatment beds would we need? How many for opioid addicts and how many for alcohol detox?
It's a hard question.
It's a hard question.
That's a great
Yeah.
question, but that's a very hard
Yeah.
question.
So one thing, are you aware of the IMD exclusion?
The what?
IMD exclusion
No.
stands for institutional disease. Right. Institution of mental disease. Anyway, there's this stupid federal law. It's been in place for years and years, and if you have over 16 beds in a residential facility, including substance use disorder, you cannot go Medicaid. And that has been a barrier.
Over 16 beds you can't be Medicaid.
Right. Yeah, and most of our residential facilities have over 60 beds. They cannot go Medicaid. So they're totally dependent on the grant funding, which has been flat or even decreased sometimes.
And that's a big problem. Half our people, if they don't have Medicaid or they don't have, or nothing, no private insurance.
The state is now applying for this 1115 waiver, which is going to take a while to go through, but if it does, we may get an exclusion from that so that they can bill Medicaid. But at the same time, what I've heard is they have limits of like 30 days on the treatment.
5 years too to get
So-
through. By the time that's approved, we'll be into a new
And
substance.
so, follow up on that, Mr. Chairman. So how long is some of the long-term treatment necessary? 6 months, a year?
Well, like I said, the average is 60 to 90 days. Some programs, like Aquila House, it's an average, the average length of stay is about a year.
So we only have a few more
Usually
minutes.
60.
Was there going to be anything from the Muni before? I'm going to go to you, Chris. But the Muni Health Department. Was there anyone else here who expected to speak or wanted to speak? Bill.
I'll defer to whether this is the appropriate time.
Input?
I mean, one thing that we want to be at the table, and we, want to be a part of this. It's definitely a health department, a public health issue, especially on the prevention end. But also, we are working to build with the local government fellow program, and are maybe hoping that we can get the fellow to work within public health to look at maybe. And we need your help on this, but we were initially thinking of maybe a community needs assessment in the area of substance misuse to really look at everything. Like, these questions are so great that you're asking, and we want the answers. And so maybe it is someone through this program that can do a community needs assessment and then be able to tell us all here what it is we do have, what it is that we need. Maybe they can compare. And so, if there are other ideas, we're totally open to that, but we want to be a part and we want to be on the team.
Sorry, could you identify yourself for the record?
Oh, I'm sorry. My name is Blanche Norman, and I'm the acting director for the Department of Health and Human Services here with the Muni.
Thank you. All right,
So
Chris.
what we did though, we funded a $50,000 grant last month or 2 months ago through Nancy's office, Stephanie Colton. The purpose of that review was to analyze what we have and what we need in terms of that campus out there and come back to us with a report detailing how we might work around the IMD, what services we might provide there. And she's kind of an international or at least national expert on the topic of these subjects. And so we actually have taken the step needed to have that conversation. And the mayor, if you look at the website right now, announced on their homeless page kind of updates, and the very last thing is the treatment campus, and it says coming soon. And so that's really where we are in this conversation, is coming soon. So,
Just to underscore what Blaine said, we are in this bit of change in the part of health and human services, but part of what we think is the coming era is really supercharging the public health component. I think you hear it directly from staff that they want to be part of the solution here, they want to be at the table, we want to unleash those creative energies. And Assemblyman Constant is exactly right. The Assembly just approved in the last few months the first two significant appropriations that should hopefully begin moving the Clifton Road ball forward in a substantive way. The first was to have the South Central Foundation spend some money to create a business model for what a self-sustaining campus could really, no kidding, look like. And the second was for the Colston Group to help us figure out if there's a way around this 1960s era nurse ratchet deinstitutionalization federal rule, using Obamacare waivers to get around the IND exclusions, so that perhaps that facility could be larger than 16 years. That money is money that has been sitting in the coffers for some time. We have a $5 million grant from the state to really move the Clifton Road ball forward, and we are just now kicking it out the door. But we hope that, having delayed the extent that we did, we are through that period, and now we really want to march forward, because the same questions that Assemblymember Croft is asking are the questions that we are trying to get our hands around too. And rather than just continue to sort of baseline the problem and grope at it from the outside, saying, well, it is a crisis and there are things we can do, we really want to get in there and make a meaningful difference. So that's part of what is to come.
I'm going to give
quick note that-
only if there's a one flew over the cuckoo's nest right now.
well, the facility providing currently those services, one floor cuckoo's nest.
Okay.
Out at the airport, the provider is leaving that site, and generally speaking, we're moving away from calling it the Clitheroe Center. That shorthand for what people understand as that place, but I think they're calling it the English Treatment Campus or something along those lines, so as not to predispose any kind of operator out there until we know what the operation should look like, because it won't be Salvation Army Clitheroe. They're leaving the shop, so just keep an open mind on the topic of who, what, and how.
All right, well, thank you all so much for your time. Thank you, Ms. LaFrance, for bringing this forward. This work session is closed.